or the broker to do it. Very good evening, Varun sir, Dixit sir, and Jyoti sir.
Good evening, sir.
Just confirm me, my screen is visible.
Yes, sir, it is visible.
Yogesh. Hello. Good evening, all the doctors. May I request to please switch on your camera so we can proceed our lecture. May I request to Jatin sir as well as Dharmesh Palodia sir and Rajan Uppaya sir to please switch on your camera so we can move to our presentation. So without wasting the time, first of all, I would like to introduce our moderator, Dr. Varun Sibal. He's a very well-known cardiologist. Currently, he is uh, HOD at our BIMS hospital in Bhavnagar. He has a widest experience at cardiology level since last 3 years, as well as he has done almost more than 1,000 plastic. So, uh, not to say much about that, but he is a very well-known cardiologist at Bhavnagar. So, over to you, Varun sir. We can proceed for our next presentation.
Good evening, everyone. I am very pleased to be a moderator today in a session where I'll be speaking about, we'll be discussing about MRAs, a boom in heart failure management. And we have an excellent faculty with us of physicians from all over. We have with us Dr. Rajan Kakia, sir. He's an MD physician at Jeevandhara Hospital. Also, we have with us other expert panelists in form of Dr. Jyotin Shah, sir. He's MD physician at Unique Cardiac Care. We have with us Dr. Rishit Nathpara, sir. He's an MD physician at Nathpara Hospital. We have with us Dr. Maulik Kaneria. He's MD physician at Kaneria Hospital. We have with us Dr. Jatin Solanki. He's MD physician at Shashwat Hospital. We have with us Dr. Dharmesh Bhalodia. He's MD physician at Satyam Hospital. We have with us Dr. Rakesh Patel, sir. He's MD physician at Naklak Hospital. And we have with us Dr. Ravi Rajani. He's MD physician at Sterling Hospital. Warm welcome to all the physicians, and let us discuss today this topic about MRAs, a boon in heart failure management. So, yes, Neerav, you are sharing the screen.
Yes, sir. I am sharing the screen. So, whenever you to change, please tell me.
Okay, so we can. I think we can go with our next slide then. So the overall, the disclaimer is that the content in the slides you're about to see is designed to gain insights and for consultation purposes and getting advice during the advisory board. It is not for any promotional purposes. And the use of brand names of drugs, if any, is purely out of habit, convenience, and not for the promotional purpose. This meeting is being recorded, but it won't be used for promotional purposes by CIPLA. And for the minutes of the meeting, we have the next slide. So the opening of the meeting we have done by the CIPLA team. So there will be a presentation and discussion, a question answer session of around 50 minutes between the moderator and the panel members. And the closing remarks would be by me and the CIPLA team. Over to the next slide. So why have we organized this meeting? The basic objectives have been to gain insights on MRAs, placement and utilization in heart failure management. We all know it forms a fourth pillar, an established pillar in heart failure management. And hyperkalemia, which is really a concern, the question comes, is it really a concern in physician practice and how much so? And to create awareness among physicians on MRAs. Coming on to next slide. So overall, we see the heart failure global epidemiology is ever increasing. The prevalence worldwide is around 26 million people, with 1 to 2% of the adult population with heart failure in developed countries. And prevalence, as we know, increases with age, rising to more than 10% people and more than 70 years of age. There are 8 to 10 million patients who are affected in India. The prevalence in India is around 1% of the total population, or about 8 to 10 million individuals. The annual incidence is 0.5 to 1.8 new million cases per year. The mortality is 0.1 to 0.16 million individuals per year. Next slide. So my first question to everyone is that what percentage of heart failure patients approach to you in NYHA class 2, 3 or 4? How many heart failure patients goes undiagnosed in India at an early age and why? So overall to panel, would so anybody would like to take it? So I think I'll ask Dr. Jyotin Shah, sir, what is your view upon this?
Sir, in routine practice, in NYHA class 4, we are seeing 60% roughly. Class 3, we are seeing 25%, and class T2 is at 15%. Usually, the class 2 stage patients are undiagnosed in early stages because of their lack of infrastructures, investigations like BNP, pro-BNP, even in echocardiography, which we are lacking in all physicians. So we are going usually by diagnosis, classically by history, symptoms and signs of the patients, and investigating by X-ray test and ECG. These are our limitations by a physician. So naturally, nowadays, all the district places have a echocardiography or even cardiologist. So it will be little bit easiest way to diagnose even class stage 2 patients.
Sir,
Here, you are audible to me, ne?
Yes, sir, you're clearly
Yes,
audible.
sir.
So what is the opinion of other panelists? Can somebody?
I think basically.
sir,
Hello.
yes, yes, sir.
Hello.
Hello.
I think basically the reason for this staging or is undiagnosed patient, I think, is basically the comorbid conditions which patients are being suffering from. So like diabetics, COPD, all those things are the main things which exaggerate this heart failure, as well as some of the times patients' history also depends. As Jyotin sir told that poor infrastructure without echo, we are not able to diagnose the patients. So sometimes the history is the only way at our centers which we can help the patients to get diagnosed of heart failures. And apart from that, we have to look for the other comorbid conditions. That is the only tool which we can use in the the diagnostic of heart failures.
Sir, even I would like to answer on this. Hello, am I audible?
Yes.
Yes, sir. Sir, about the first question which you have put on in front of us, that what percent of heart failure approach to you in NYHA 2, 3, and 4. So what I would say, like to comment on this is that maximum, like it depends upon the infrastructure, kind of infrastructure you're working. Like I am working in a tertiary care hospital. So the patient would land up in NYHA 4 and then only come to us. So most of them are coming to NYHA grade 4. And other than that, NYHA grade 3 and 2 are also coming, but 2, I guess, most probably have their other complaints of heart failure like pedal edema also. So then, and the second question which you asked, that how many heart failure patient goes undiagnosed in India and why? So I think many of the patients, like more than 50% of the patient are going undiagnosed. That is because, as our both expert panelists said, that lack of infrastructure, that is 100% true. Other than that, I would like to add is the patient, the lack of awareness amongst the patient. The patient have the tendency, even the patient has the tendency to ignore their symptoms. And other than that, the other reason can be that the misdiagnosis, sometimes it can also be misdiagnosed as bronchial asthma or COPD if the patient has a significant history of smoking, or it can also present with both of it, like even the patient can present with acute exacerbation of COPD associated with heart failure. So all these reasons also contributes to the patient who are getting undiagnosed in India. The first reason, of course, as our expert panelist said, that lack of infrastructure, and because you don't get anti-pro-BNP, I don't think many of those government medical colleges or medical hospitals have TROPI or this thing, anti-pro-BNP. So the diagnostic tool is mostly clinical. Other than that, the 2D echography, of course, and the ECGs. Thank you.
Okay, I think that clarifies most of the doubt. My second question to our panelists is, what are the diagnostic and prognostic tools used by you for heart failure patients?
Most of the times, sir, the only thing is that Jyotin sir told that like it is the ECG and X-rays. That is the only thing. But main thing we focus is on the history, because many of the times patient has got an exertional dyspnea or most of the symptoms which go most of the times undiagnosed, especially the patients which comes from the village side. So the only thing is with us is like the history, the clinical examination, and X-ray and ECG. That is the only thing. And apart from that, some of the times we go for echo, but that depends on the patient's financial conditions. So that is the tool, as well as some of the times what I practice in my field is like we used to give the medicines like diuretics or what all things like for a short period of time. That also sometimes help us to diagnose without any further investigation, because most of the patients are not affordable that such. So what I practice is like giving the medicines for the 10 days and again asking them for the follow-up. If the symptoms relieves, that also will many of the times help us to diagnose like the conditions of heart failure or any of the supportive conditions like comorbid conditions.
Like the empirical treatment.
Yeah. That is because some of the times most of the patients are not affording, right? And some of the centers like where I am practicing, we don't have the infrastructure of echocardiography. If it would be there, then it would be very much easy. Like direct diagnosis would be easier. But patient, first thing is patient will not or they will not be agreeing to go to the higher centers. And second thing is that the financial. So that is the only thing. And many of the times we do diagnose good, but the only thing is that, as sir said, the most of the patients coming at the later stage of the disease. So hardly we get sometimes in the stage 2, but stage 3, 4 patients also are not less. We also encounter such stage patients as well, because they would not be taking the regular medicines.
Sir, even I would like to answer on this, like the question which you have put on, what are the diagnostic and prognostic tools? So in my case, as I'm working in a corporate hospital, for me, the diagnostics tool is, of course, the NT-proBNP. Other than that, of course, TROP-I to rule out ACS-induced heart failure. And for the prognostic, of course, 2D echo to know the kind of heart failure, whether it is secondary to the acute coronary syndrome or whether it is secondary to any other thing. Depends of course the ejection fraction to know the ejection fraction of the patient, whether the heart failure is with preserved ejection fraction or reduced ejection fraction. And talking about the prognostics tools, I think majorly it is clinical, which gives us the prognostic idea about the patient. Now, suppose if the patient is in cardiogenic shock, the prognosis becomes extremely poor. And then it also depends upon the age and sex of the patient. Like what is the age? The more the age, the poor the prognosis, as we say. And other than that, also that depends upon the other parameters. Like if he is having other comorbid conditions like diabetes or hypertension or hypothyroidism. And other than that, if there is any co-infection along with heart failure, many times even infection exacerbates the heart failure. So if there is any other infection associated with heart failure, again, the prognosis becomes little poor. And other than that, other prognostic tools, as sir said that, yes, we can give a trial of diuretics and, diagnostic tool. As sir said that we can give a trial of diuretics, because sometimes the patient comes early and NT-proBNP, as per my knowledge, takes at least 24 to 48 hours to come to the maximum. So sometimes patients with heart failure coming in acute stages have normal proBNP. So in that case, we can give diuretics if there are basal crepitations or the HRCT or your chest X-ray reveals cardiogenic pulmonary edema. You can give a trial of diuretics and see if the patient gets relieved. Then yes, of course, it was heart failure, and then you can treat accordingly. And other than that, a prognostic tool, one more, which can say that we can monitor every third day, we can monitor the patient of NT-proBNP of the patient. If it is in the reducing trend, we can say the patient is improving. If the patient has no other clinical parameters are normal. Thank you.
Okay, that was a nice discussion. So there has been a 2021 update to the 2017 ACC expert consensus decision pathway for optimization of heart failure treatment. It says that caution should be exercised when MRAs are used in clinical practice. Serum potassium levels, if they are more than 5 milliequivalents per liter, you have to be concerned. And in patients who are having severe CKD, more than stage 3, that is stage 4, or a creat level more than 2.5 milligram per deciliter in men and more than 2 milligram per deciliter in women. Next slide.
1 minute, I can say for
Yes, sir.
question number 2, I
Yes.
summarize the,
Yes.
sorry, I'm little late, but I summarize the question number 2,
Yes, sir.
diagnostic and prognostic tools used by us is definitely described properly by Jatin and Ravi. But theoretically, in a study purpose in a medical college, we require lot of steps which has equal importance. I say you consider history, symptoms and signs of the patients. You confirm by BNP, pro-BNP and echocardiography and assess phenotype, clinical phenotype, whether heart failure is reduced with ejection fraction, reserved with ejection fraction, or moderately reserved with ejection fraction. You find out the risk factors and try to investigate about comorbid conditions. You access your MRI, angiography, or biopsy, or echocardiography, and workup to be done for targeted therapies to be just like you have said, kidney functions and other comorbid condition, so that thyroid, something like that, so that all these investigations should be done. If it is available, if we can do in a higher center, then we come to clearer pictures of the heart failure stages and prognosis of the patients. Even we can see rehabilitation, awareness of the patients as well as doctors to be included in our diagnostic tools. Okay, thank you.
I think Jotin sir's net is not on a very good side.
Hello. Are you
Yes, sir.
hearing me? Hello.
Yes, sir. You're
Okay.
comfortably audible. Meanwhile, Dr. Varun sir just joining in just 2 to 3 minutes. Meanwhile, I would like to ask if any panelists want to ask, give his opinion regarding the usage of means, they are testing before using MRI like a potassium level, creatinine level, as well as EGFR. If any doctor want to give their opinion.
Anybody can are these parameters before and after MRI? Yes or no? Hello.
Jyoti sir, you are not audible. Hello.
Hello. Hello.
Yes,
Okay.
sir.
Now,
Yes, sir. Yes, sir. Now
are
comfortable.
these parameters tested before and after initiating MRAs? And how? Hello. Hello.
Yes, sir. I think there is a network problem. Yes, sir. Go ahead, sir.
Anybody wants to give the question-free answer?
Yes, Rakesh sir, or Dharmesh Palodia sir, or Jatin sir.
Yes, so I would like to answer this question. Are these parameters like the potassium, creatinine, and EGFR tested before and after initiating MRAs? So, see, what I would like to say in this case is that any patient who is getting treated by us for the heart failure, any basic, so the basic baseline tests that we do includes the potassium, creatinine, and from the creatinine, of course, we get the idea of the EGFR. So I think, and especially for before starting MRAs, of course, this should be checked because the MRAs, of course, is a very good effect, very subtle, very good effect on the potassium levels and the creatinine. And of course, we all know that there is something called diuretic-induced AKI. I have seen many patients who are coming with a very bad heart failure, and we give aggressive diuretic therapy, and after 2 to 3 days, they develop an AKI, and we stop the diuretics, and the AKI got resolved on its own. So yes, of course, these parameters, the potassium level, creatinine, and EGFR should be tested before starting the MRAs. And for how long? I think initially after the patient is discharged from the hospital and you're continuing the MRAs post discharge, then I think for initially it should be tested aggressively, like at least every 2 weeks. And after that, once we know that the patient is adjusted to the required optimal dose, then after that we can prolong the duration of the this thing testing or the follow-up, which when we call the patient for the follow-up. So that is what my opinion is. Thank you.
I have one question that after we start on MRAs, in routine practice, how frequently you just you go for potassium level testing? Means how frequently we have to call for the patient, like in the follow-up, once the patient is got stabilized, once the patient has started on MRAs. So how frequently we should check for the potassium and create levels?
Sir, as I said, I think that what I follow is that after the patient is discharged from the hospital, after the patient is being stabilized, discharged on MRAs, the first follow-up I call is for just after a week, and with creatinine and potassium. And after that, once if that is normal, then the week increases. It increases each week. Like then second follow-up becomes after 2 weeks, third follow-up becomes after 3 weeks, and then after a month, and then every once in 2 months. So it keeps on increasing. But I think at least what I would suggest is that patients should be tested for potassium and creatinine levels for at least once in 3 weeks. That is what I feel. And of course, because of course we know that this MRS has a effect on the kidneys and the potassium level. So that is what I feel.
Our patients are from rural mostly, so we have to try to keep a minimum dose of diuretic and MRA. So if patient not come regular follow-up, that doesn't affect our electrolyte disturbance. So we have to keep try to minimize the dose of diuretic and MRA.
Of course, in the rural setup, of course, we have to minimize the dosage of the MRS and diuretics. But you know what I have observed is whenever the patient is admitted with us in ICU or wards or whatever, we get the baseline idea. And I think after 3 days of the aggressive diuretic therapy, we know that now what will be the optimal dose patient will be requiring for his further follow-up. So I think in that rural setup, when the patient is admitted, you get an optimal idea. So, but yes, of course, as you said that after discharge, you have to keep minimal dose. And if the patient is unresponsive to the minimal dose after follow-up also, then you can, gradually increase the dosage of the MRS and diuretics.
So,
I think all the speakers are correct because it depends on individual patients and individual situations. But frequently we should monitor. As the patient stabilizes, we increase the duration of the frequency of the investigations, in short. Okay.
So I think 3 monthly, once the patient settles down, we have to repeatedly do serum electrolyte, serum creatinine to see whether the potassium levels and electrolyte levels are maintaining or not. Because many of the time, depending on the management, it involves the use of diuretics, loop diuretics. Sometimes it involves use of hydrochlorothiazides, chlorothalidone, and also with use of eplerenone. So we have to see whether the patient is going on hyponatremia, hyperkalemia. All these factors need to be monitored very frequently. So that was a nice discussion. Towards our next slide, Neerav, can you go to next slide? So the heart failure guideline recommendation for MRAs according to the AAC guidelines for heart failure with reduced ejection fraction, it is class 1 indication to reduce the risk of heart failure, hospitalization and death. While with mid-range ejection fraction, it is they may be considered to reduce the risk of hospitalization and death. Next slide. So as I discussed earlier, whenever we are managing heart failure, there are 4 pillars. One is ACE inhibitors or ARNIs, another is beta blockers, the third is MRAs, and the newer one is SGLT2 inhibitors. So basically what we go is like we initially stabilize the patient. Obviously loop diuretics, and if the patient is heart failure with reduced ejection fraction, they play an important role. Consequently, the focus remains after stabilization on up titration of ARNI and beta blockers, and also with SGLT2 inhibitors. The practice which usually goes by in the European setting is like we start them all 4, try to start upfront before the discharge, wherein we can achieve a faster rate of optimum medications. If suppose the patients remain symptomatic and there is scope of improvement even after 3 months of lifestyle modification and adequate drug therapy, then other interventions in the form of CRTP or D or ICD can be done. Along with some comorbidities, if the patient is having atrial fibrillation, we can start the patient on anticoagulation. If there are other valvular factors like aortic stenosis, we can go for SAVR or TAVI. With mitral regurgitation, it is now becoming an upfront indication that if the patient is having severe MR, secondary MR, it needs to be repaired. So MV repair has to be done. And heart rate, if not stabilized with beta blockers below 70, so evaporating can be added. And for black race, and in fact the patients who are having serum creat on a higher side, we can use hydrolysine and isosorbate nitrate. And iron deficiency need to be addressed. Correct. Especially I would like to say that ferrous carboxy maltose, it works wonders. I have many patients. It is not like oral iron is not useful, but the thing is that patients with heart failure actually have gastrointestinal edema, and henceforth the absorption of iron from the gastrointestinal tract remains limited. I've seen practically in many patients that if you supplement oral iron versus you give them IV iron, the response is very quick. Not even quick, it is quite sustained. So we have to do all iron parameters at that moment of time. And for selected heart failure patients, if they are not responding, they are upfront candidate for heart transplantation, and mechanical circulatory support can be given for bridge to transplantation or bridge to transport. And to reduce heart failure, hospitalization and improve quality of life, they do need exercise rehabilitation and multi-professional disease management. So coming to our next slide. My fourth question to our Dr. Maulik Kaneria, sir, is there. In what % of patients do you use MRAs for heart failure management? Dr. Maulik Kaneria, sir. So I'll pass on the question to Dr. Ravi Rajani, sir. He's there. In what % of patients do you use MRAs for heart failure?
I think, sir, in my practice, I have used MRA in very low amount of patients as of now. I think most of the patients are responding to the torsemide or this thing, what we say, furosemide. So I think after that, if the patient are not responding to those, then we can think of the MRAs. I think, as you said in your previous slide, that the first upfront, the ARNIs or the ACE inhibitors, along with beta blockers and SGLT2 inhibitors like dapagliflozin or any this diuretics should be started. So if the patient is not responding to the initial diuretic therapy, then I think the MRAs is a very good option. But most of the patients, I think more than 50% of the patients are good enough responding to the initial diuretic therapy. Other than that, if the patient has a very low ejection fraction, I think if less than 25% of ejection fraction, then I think without giving a second thought, the MRA should be considered as even the first line of treatment, because then it has a very good effect, because along with the other diuretic, loop diuretics also.
Okay. So our next question is to Dr. Rakesh Patel, sir. When do you consider starting MRAs in patients with heart failure along with ACE inhibitors and beta blockers?
Yes, I consider starting MRA if persistent of symptom, the patient is in HYNA class 2, 3 or 4, LVEF less than 40%, on optimal dose of AC inhibitor or ARNI and beta blocker, then and then I add MRA. But we have to take optimum dose of AC inhibitor. Suppose the patient is on Ramipil, so sometimes we start only 2.5 milligram Ramipil or 5 milligram, but we have to titrate the dose of AC inhibitor with monitoring of serum creatinine and serum potassium after optimum dose of AC inhibitor or ARNI beta blocker and diuretic for symptomatic treatment. After patient is stable, not volume overloaded, fetal edema is gone, breathlessness is gone, then we have to decrease the dose of diuretic. But after optimal dose of all these three, then patient persists symptom, then we have to add MRA.
Okay. So I would also like opinion of Dr. Dharmesh Balodia sir on this question. I think Dr. Jatin Solanki sir might like to take consider his opinion on this. Dr. Jatin Solanki sir.
Sir, Jatin sir, you are on mute.
Okay, sorry. As Rakesh Patel sir told rightly, that at least first of all, the optimal doses of beta blocker or ARV, whatever we are using, should be given. And according to patient, actually in sometimes periphery setup, what happens that patient, we are losing the follow-ups of the patient because they are due to whatever may be the reason. So at least minimum dose of MRS we are using according to symptoms. If patient is having low ejection fraction or a patient is more symptomatic like having grade 4 NY, if patient is less symptomatic, then we tend to start with only diuretics. Then if when necessary, we are adding on the MRS.
I must suggest that if the patient renal parameters are normal, then the best option is that we should go for the combination therapy like diuretics as well as MRAs, because only giving the diuretics may cause harm only at the electrolytes level. So only diuretics may cause the electrolyte imbalance, and that thing we have to monitor regularly. So I think best thing is like if we are starting with the very low dose of diuretics as well as the MRAs, then it would be the most sufficient and it will be on the safer side rather than giving only the diuretics. Because definitely most of the patients we are monitoring, they will get somehow low sodium levels. They will go for hyponatremia because most of the patients. Yes, sir.
Yes, you are right. Because diuretic only gives symptomatic relief. There is
symptomatic relief.
There is no prognosis difference for giving a higher dose of diuretic. After symptom is corrected, breathlessness is okay, no fetal edema, then we have to taper down the dose of diuretic. Otherwise, that causes the harm. Yes.
Yeah, better to give the low dose and combine with both the medicines.
Yes.
So that will benefit mainly on the electrolytes. And after that, only thing we have to monitor is only the potassium levels, main thing. And while giving only the diuretics, we have to monitor all the things. Because as such, previously sir told that a patient giving a lot of diuretics in heart failure patient, they will go for AKI. So that is the thing. We have to monitor create, we have to monitor sodium, we have to monitor the potassium. And in the small setups like in which we are practicing, we have also financial constraints. So if the patient is on such low dose, then we only have to monitor like the potassium, and every 1 or 2 months we used to do the create levels. So if the create is normal, so I think that the best thing is to give the combination at the very low dose.
Coming on to our next slide. So there is something known as aldosterone escape phenomenon in congestive heart failure, and which demonstrates the importance of the time of initiation of mineralocorticoid receptor antagonist on risk of mortality in patients with heart failure. So MRAs, what it says, like the early we started as early as possible on the top of treatment, including ACE inhibitors, ARB, and beta blockers, preferably at discharge after an episode of decompensated heart failure. Following an acute fall in aldosterone in response to administration of ACE inhibitors, the level of aldosterone rises again and indeed returns to baseline in almost all patients, a phenomenon known as aldosterone escape. So whatever we are trying to achieve with ACE inhibitors might be counterfeited by this. Even when the ACE inhibitors is given in combination with an ARB, aldosterone level remains uncontrolled. Usually we don't give it. Aldosterone escape might promote the release of angiotensin 2 via positive feedback loop that stimulates ACE in the vasculature. The progressive escape of aldosterone are thought to contribute to ACE inhibitor resistance, whereby the effect of ACE inhibitors becomes blunted and beneficial effects on mortality decreases over time. Whereas MRAs are able to antagonize the deleterious effect of aldosterone, resulting in a beneficial effect on overall patient mortality. Coming to next slide. So when we are comparing the two MRAs, that is spironolactone and eplerenone, on LV systolic function in patients with heart failure, usually the overall end-on improvement which we suggest, depending on the echo, that is left ventricular diastolic volume, or we say end systolic volume, LV ejection fraction, are comparatively slightly better than eplerenone, and we can say that it is statistically these values are significant. So eplerenone compared to spironolactone is beneficial, although in any cases eplerenone is a bit costly. You can use spironolactone. Only thing with spironolactone, one of the complications which arise very frequently is that painful gynecomastia state in males, so which is very rarely seen with eplerenone. Coming on to our next slide. So my next question to Dr. Rajan Kakia sir is, when do you prefer using eplerenone and spironolactone? Any specific patient profile? I think Dr. Jotin Shah sir can take up this question. When do you prefer using eplerenone and spironolactone?
Because of economical condition, we are using spironolactone routinely. If male patients has a gynecomastia painful, then we are switching over to eplerenone in our routine practice.
Yes. Yes, sir. Kalpit.
Apart from that, eplerenone is more receptor specific, so it is definitely the best option if the financial problem is not there.
Yes,
and spironolactone is more potent, while eplerenone is more specific. It has got more specificity.
Yes. Jotin sir already said very good. If economical is, then we have to start spironolactone, and if endocrinological side effect occur like gynecomastia, breast pain, then we have to shift eplerenone. If there is no problem of economy, then we straightforward start eplerenone.
That's a nice point of view. We'll go on to our next slide. So hyperkalemia management in heart failure, and how can we modify these drugs? So depending on the potassium levels, usually about 6 levels, if the potassium level is more than 6, we can discontinue, and below 4 we can usually use it very frequently, and up to 4 to 5.4 we can use it quite judiciously as per our recommendations. We can progressively increase the dose of spironolactone from 25 milligram to 50 milligram per day, and in eplerenone we can increase it to up to 100 milligram per day by starting it from 25 milligram per day. Dosage adjustment may be needed if the potassium levels are on a higher side. So renal function should be adjusted. The basic necessity of the slide, we have to assess for EGFR. We have to assess whether the patient is not hypotensive. So all these factors should be taken into consideration before up titrating or down titrating the dose of spironolactone or eplerenone. Coming to our next slide. So my next question is to Dr. Rishit Nadipara sir. then what is the preferred dose and how is the dose titration carried out in your practice? How do you do it?
That thing basically, as you told, it depends on the blood pressure levels and also the renal parameters. That is the main thing. So basically, I generally start with the very low dose, and gradually we go on the dose to increase, depend on the patient's hypertension, patient symptoms like the chest, the auscultation of the chest. That all things matters the most. But initially, generally, we most of the times use spironolactone. We go for 25 milligram. And as I told previously, I generally prefer to go with the combinations like diuretic with MRAs.
Just and one of the things I wanted to ask that suppose if the patient's ejection fraction over a period of time, now with ESC guidelines progressively classifying the patients upon ejection fraction, with reduced ejection fraction, suppose if the patient comes about 25%, now it improves to 45%. So you still continue with the loop diuretic and or how do you go about with it?
Yes, we continue with the same, but that I think that if the patient is even if stable with the low dose, then we can continue. But the only thing is that the monitoring should be there, and patient has to be advised to get frequently check the electrolyte levels. So once the patient gets stabilized, I prefer to continue with the same medicines.
Okay. So coming, so that's a very nicely answered question. Moving on to our next slide. So what is the incidence and how is MRA-related hyperkalemia? The true rate of mineralocorticoid receptor antagonist-related hyperkalemia in placebo-controlled trials, a meta-analysis was done, wherein it was found that the prevalence of hyperkalemia was 9.3%, out of which 54% was truly related to MRAs. So it is around 50% we can say because of MRAs was there. Coming to next slide. My next question is to Dr. Maulik Kaneria sir. What percentage of heart failure patients on MRAs develop hyperkalemia in your practice and do they require discontinuation of the treatment? Dr. Maulik Kaneria sir, are you there? I think the question can be taken upfront by Dr. Ravi Rajani sir. What percentage of heart failure patients on MRAs develop hyperkalemia in your practice and do they require discontinuation of treatment? So I think Dr. Jatin Solanki sir might like to answer this question. Okay, yes sir.
Mostly in our practice, hyperkalemia with MRS, we are seeing in at least 30 to 40% of the patient, but at long term. But with proper dose titration, we can bring down that number. So require at least not discontinuation, but first of all, during the acute presentation of any kalemia or something. Hello?
Yes, sir. Yes, sir.
Am I audible? Yeah.
Yes, sir.
With hyperkalemia, at least first of all, we should during acute presentation of hyperkalemia, we need to stop the treatment for some time, and after some few days, we used to start with at least low dose. The patient, how much patient can manage by himself, or patient body should tolerate it.
Okay. So I think Dr. Solanki sir has answered both question number 8 and question number 9. So moving on to our next slide. So the timing of eplerenone initiation and outcomes in patients with heart failure after acute MI complicated by left ventricular systolic dysfunction and insight from the classical FSS trial. It was found that an earlier eplerenone administration 3 to 7 days post-MI improved outcomes in patients with LV systolic dysfunction and heart failure. And this benefit was not observed when eplerenone was initiated quite later. So eplerenone should be started as early as possible in LV dysfunction patients, so as to we can inhibit the pathways. Coming on to the next slide.
Sir, I want to ask one question. Like in the MI patients, like each and every patient we should go for, or depend on the comorbidities, or like ejection fraction, on what basis we start the patient this eplerenone after MI?
See, after MI, what we go about is like first we don't start it on the acute phase if the patient is in a shock. So first of all, he needs revascularization classically. After that, we start the patient after MI on beta blockers and Hermes upfront. Second or third day after stabilization, we can start the patients on liprinone. Does serve the benefits. If the patient is having LV systolic dysfunction, we might consider adding SGLT2 inhibitors upfront if the patient's blood pressure allows us to. That's how we go about it. I hope I have answered the question. So coming on to the next slide. Earlier administration of eplerenone did improve the outcomes in patients with LV systolic dysfunction and post-MI according to FSS trial, as we have already discussed, as compared to placebo. Coming to next slide. My 10th question is to Dr. Rajan Kakia sir. In clinical practice, how early is our MRIs initiated for in your practice for management of heart failure patients? How lenient are you with that, and how do you start it? I think Dr. Dharmesh Balodia sir would like to take up the question. Dr. Jotin Shah sir, if you're there, you can take this question, sir.
In my clinical practice, I start after 3 to 7 days of stabilization of the patient MRI. And it should be continued at least more than 6 months in a acute myocardial infarction patients who have already reduced ejection fractions. In heart failure patients, we give lifelong with monitoring of the potassium and EGF.
Okay, so it answers our question. And coming on to next slide. So what is the therapeutic algorithm of class 1 therapy indications with HFrEF? So as I've told earlier, the newer guidelines, especially the European guidelines, I'm not commenting about the American guidelines, both the guidelines differ. So we have the American guidelines, we have the European guidelines, we have the Canadian guidelines, we have the guidelines from Denmark is there. So apart from American guidelines, which still classifies that ERNI and beta blocker, after some time start on MRAs, and SGLT2 inhibitors, they are not yet listed, but they do start after some time, and loop diuretics upfront for symptomatic management. The other guidelines are in consensus that they should be started as early as possible, all the 4 pillars. And as I've discussed earlier, if with that the patient is symptomatic, or with the medications and lifestyle modification, after 3 months of the patient has attained the therapy, is stable on therapy, and EF does not improve, we can think of intervention depending on ECG in form of ICT or CRT. Coming to next slide. So my next question to Dr. Rakesh Patel sir is that what stage of heart failure diuretics and MRIs both are needed?
Yes. In acute heart failure, we start in indoor patient always loop diuretic. After stabilization of the patient, clinically okay. Then on discharge, we put on patient diuretic, loop diuretic plus MRA, and my combination mostly spironolactone plus torsemide. If in future spironolactone induce endocrinological problem like gynecomastia, then I shift to eplerenone plus torsemide. So always start in acute condition is loop diuretic. After patient stabilization, hemodynamically patient is stable, blood pressure is okay, serum creatinine, serum potassium is okay, and then on discharge mode, I shift to combination of therapy.
Okay, so it answers most of our questions. So yeah, definitely the answer is very well understood and very well explained. At initial phase, we should start the patient on loop diuretics, and after some time we can add MRAs. And choice of MRAs depends on the patient condition. Both are good according to the condition. It's not bad. Patient has to be on some MRAs rather than not on any MRAs. Very beautifully explained. Coming on to our next slide. So all panel members, and you can say question 13 and 14. So, question number 13 is, in your practice, any other indication apart from heart failure where MRAs are used? And what scientific initiatives would you suggest to CIPLA for increasing awareness among the common people?
Yes. My one answer is MRA is used in my practice is in resistance hypertension. If patient using more than 3 group of hypertension on optimal dose, not subtherapeutic dose, then I always prefer MRSA, and also MRSA are indicated in resistant hypertension, and the results are very good.
True, true. That is one of the needed indications, sir. Absolutely, you are bang on right on that.
Other than that, I think MRS spironolactone is a very good option in alcoholic liver diseases which have portal hypertension, decompensated
Yes.
alcoholic liver disease, cirrhosis, of course, with portal hypertension
Yes,
who has
it is.
fluid overload.
Yes, it is there, sir. So, any suggestions to CIPLA, sir, amongst the other panel members you'd like to give?
I would like to add more indications for spironolactone. And first is the primary aldosteronism. Then doctor has said that it is in resistance hypertension. Second, post-myocardial infarction, which we have already discussed, to prevent heart failure and to reduce the fibrosis of the regional wall. Second thing, we want to prevent heart failure. Even we can give in a small dose in LVH, left ventricular hypertrophy also.
Yes.
Third thing, we can prevent chronic renal disease, in which cases patients have a proteinuria. We protect renal protection in proteinuric chronic CKD patients with all monitoring of our creatine, eGFR, and potassium. So there is a wide indication for MRA.
Yeah, they all are very valid indications, sir. So, coming to the next slide. So, I'll like to thank all the panelists who have devoted their valuable time out of their busy practice, and come for this forum. I also thank CIPLA team for organizing such meetings. They might be an eye-opener on how to use all the drugs. And definitely, I'd like to summate the meeting in a nutshell that yes, MRAs are one of the drugs of the 4 pillars which have to be used. The early initiation is not encountered with many complications as compared what I have seen in my practice. Is 2 to 3% of the patients hardly which are having, actually less than that, which are having episodes of severe hyperkalemia, and especially deleterious hyperkalemia causing death. So hyperkalemia should be adjusted accordingly, and we have to balance the dose depending on the patient's clinical condition and the blood pressure and renal parameters. So again, I would like to thank everyone. It was a very nice meeting and a nice evening. So to all the panelists and to I think Neerav Rajani, you would like to say something from CIPLA?
Yes, sir. Yes, sir. From CIPLA, sir, first of all, I would like to thank you all the panelists who have interact very well and gave their opinion regarding MRA, usage of MRA. And also would like to thank Dr. Varun sir, who has taken up this lecture and discussion at a very high level. So it was a wonderful session overall and a wonderful discussion at MRA point. So thank you very much once again from CIPLA to participate and spending a time.
Okay.
So thank you everyone. With that, I call it a day. And I hope with this we are enlightened with use of newer drugs, and the meeting is successful in some ways in promoting a good message. So good night for today. Thank you for joining.
Thank you.
Thank you. Good night.
Good night.
Good night.
Good night, everyone.
Thank you so much. Thank you, sir.
Rama.
રોશન ગોપાલે મને કીધું હતું મને કે લગાડજે એમાં કઈ નુકસાની આવશે નહીં આ લોશન તો કદાચ ખંજોરમાં કઈ સારી હા આવશે કેલામાં નાખશે બરાબર એ તો આવી કીધું પણ આ અત્યારે ચાલુ ન કરતો એમ કીધું બરાબર ખંજવાળમાં અને ક્યાંય હોય તો હું લઈ ગયો તો તરત જ ફોન કરીને મગાવી દીધી હતી હોટેલ મેડિકલ માંથી માણસ ગયો તો નીકળે દેતો જાય આ બધી વસ્તુ ત્યાંથી આવી દીધી એટલે આ તો મને કીધું ઈ તો કદાચ ઇન્જેક્શન દઈ ગયું તોય લગાડજો તોય વાંધોમાં કઈ વાંધો નહીં આ તો સેફ અમે ઉલટાકના રિએક્શન આવે તો યાદ દઈ એમ કીધું એટલે આ ના પાડી મને કે ઈ હું કહું ને તો થઈ ગયા નકર ત્યાં સુધી ન દેતો બરાબર રિપોર્ટ તો અસર જ વાર લાગે એવું અડધો પોણો કલાક જેવું થઈ જાય વાંધો નહીં જો ફટાફટ આવી જાય તો જોઈ જાય સાર ચાલતું હશે તો હું બેઠો જઈશ તો પછી નકર એક કામ કરજો જો નહીં જાય પછી રિપોર્ટ તો વોટ્સએપમાં તમે મેલ આવે ને તમને વોટ્સએપ નાખી દે મેડિકલ ની દવા જે અત્યારે લેવી પડતી હોય જનરલી તો બહુ કઈ આવશે નહીં કાલ સવાર ઉપર જ જશે આમાં માનો કે યુરિનમાં કઈ ઇન્ફેક્શન આવે તો એની દવા મારે એડ કરવાની થશે બાકી રિએક્શન કરવાની અત્યારે દે ગરમમાં ગરમ નાખી રાખી ત્રણ ખાવું દે એટલે પેલા એકવાર હે ને એલર્જી બેસી જાય ને શરીર ખંજવાળ બેસી જાય પછી બધું કરાય ઇન્જેક્શન તમને દુખતા કેમ નહોતા મારું માથું એટલું દુખતું હતું મને ઇન્જેક્શન ની ખબર જ નહોતી હાલે હું તો અને ધર્મેશભાઈ ખરેખર મારી લાઈફ ની અંદર માથું ગોદી નથી દીધું આ પેલો રેકોર્ડ એમાં શું 4 દિવસે અમારા મંડપ નું કામ એટલું થોડું સફર હાલે આવડું કામ ખરાબ ઉપર કારીગર લઈને ભાગી અને તડકાનું જ ઉભું રહેવાનું કે સાયદ હોય નહીં અમારે સાયદ કરવાનું અમારે ક્યાંય હોય નહીં તડકે ઉભા રહે શું દશા એટલે અત્યારે તમારે લૂ લાગીને માથા દુખે એવા કેટલાય આવે એટલે અમે એટલે તો મેં કાંઈ કર્યું નહીં તમને ફોન કરી અને સીધો જ આવતો મારે ઇન્જેક્શન દેવું નકર મટેમ જ નહોતું દવા સીધું 15 મિનિટમાં થઈ ગયું 15 મિનિટમાં કાઢી માથું ઉતરી ગયું કેવું હતું ખબર ન પડી હા